I'm right on time, although I started late, so I'm really excited to see our colleagues from the intensive care unit. It's really wonderful to have you here, and even some folks from the hospice program. I really appreciate your coming on time. I think we're going to have a very thought-provoking presentation today. It comes out of a lot of work that Dr. Clark and Dr. Roberts have done. I'm told that the only difference between them is one N. I'm not sure that I accept that premise. Joan is a member of our ICU team, as is Jonna. Both of them attend in the PICU. Jonna has done some really thoughtful work around end of life and quality of care. Joan, just as an all-purpose, a very skilled individual. I think Joan starts.
We're together.
I'm sorry, they start as a team.
Good morning. Thanks for coming. We wanted to do a presentation together for you on limitation of resuscitation, using dialogue to promote quality of life and death. Our work is represents the work of End of Life Work Group, which is an ad hoc group of people that gets together once a month for the past couple of years to talk about what we could do better to promote end of life issues for our families. Up front, we want to be clear on disclosures. We will gain nothing from any of this work, nor will anyone we know or anyone we hope to know. And throughout this talk, we have interspersed comments that we have from the literature from both physicians and families. In doing this work, we found that it was equal parts thoughts from the scientific world that are portrayed in numbers and in facts, as well as the dialogue we had from parents, families, and the written words of families who have lost a child. And throughout our talk, we'll intersperse these words of the heart because it's really the interaction of the two things that come together in this work.
And our first quote is from Dr. Feutner, one of our former Seattle Children's alum, who stated, "Let us communicate with each other clearly, compassionately, and collaboratively as we strive to improve the quality of life for children, including when necessary. That part of life is dying." And our overall goal of this talk is really to highlight the importance of communicating with families to provoke collaborative efforts in terms of improving the quality of life and deaths for our patients. And in this talk, we try not to advocate for any conflict between parents and providers in terms of different decision making, and rather we really want to help develop a partnership with our parents and families in order to improve their quality of care that they receive, the quality of life and the quality of death for their children. We believe that by developing therapeutic relationships early on, emphasizing goals of care rather than individual therapeutic interventions, that we hope to reduce suffering in our patients, especially children who are dying.
We were asked to provide objectives for what you would walk away from with this talk, and we hope that you leave with an understanding of the evolution of CPR, as well as the process for writing orders of limitation of resuscitation. Our big ask is that you take on the responsibility of integrating the values and goals articulated by families during the discussion of end-of-life issues and turn those into the actions of providers and nursing staff. That's a big ask. We hope that we have developed new documentation process to clearly and concisely state the goals into the medical record for patients, for any patient really with a reasonable chance of mortality during their hospital admission. To start with, much of this work was inspired by the accumulated review of Code Blue responses. And we're going to go through some vignettes that highlight the current state and the issues that we have right now. So our first vignette is an 8-year-old girl with acute myelogenous leukemia who is now status post-bone marrow transplant ×2. She's admitted to the ICU at 2 in the morning with acute hypoxic respiratory failure and septic shock. The ICU team asked the medical team who's covering overnight, how much do we do? How far do we go? And the medical team covering says, we don't really know. We think you should do everything. The ICU team turns to the family and she says, "Why are you asking me whether I want my child treated? Of course I do. My daughter is a fighter and she's going to get through this." So due to the fact that there is not a consistent and clear place to write down the conversations that undoubtedly have happened in the long course of this patient's illness, the ICU team is confronted with a lack of clarity about what they're supposed to do. At this highly emotional and fragile time, there's a change of services and providers. The family is exposed to repeat conversations and questions when they're emotionally fragile. The family is also expected to be rational during this time. And this absence of documentation over time, unless there is a specific limitation that has been reached, is a sort of factual impediment in our system right now.
Without consistent providers and communication with families, when parents are continually asked what interventions they want performed, parents do become frustrated. They tend to become more forceful advocates for prolonging the lives of their children. Foreman is a mother of a former premature infant who actually initially requested no resuscitation of her preemie, and eventually she came to this quote: "I'd been able through the force of will and instinct and a fierce attachment to my son to see him to a place no one would have ever predicted for him." And furthermore, we get in a qualitative study of many families who chose to withdraw life-sustaining therapies in their loved ones. She summarized many of the quotes of families by saying, "Families hoped and many prayed that their family member would prove the healthcare team wrong and improve."
Our second vignette is that of a 2-year-old boy with an undefined progressive neurodegenerative disorder. This patient has chronic respiratory failure and is supported with non-invasive mechanical ventilation, or BiPAP. He experiences daily episodes of bradycardia to the 30s, requiring intermittent CPR, typically only a few minutes in duration. And on admission to the PICU, mother requests everything be done for her son. Over the next ensuing weeks, with these repeat episodes, no clear understanding of the outcome of this underlying disease, moral distress among medical providers in the ICU increases. Every week, a new PICU attending, and possibly every evening as the shift change turns over, code status is addressed over and over. "Do you still want full resuscitation?" And the parent replies, "Yes, I want everything done for my child. How could I not?" Private discussions involving slow codes evolve in response to this repeat episodes in the face of unlikely survival. And finally, tension develops between the medical care team and the mother as she expresses extreme struggle with the decision that she is being asked to end her child's life, not the disease process. The lack of goal-oriented conversations regarding options surrounding end-of-life care results in an escalation of conflict rather than alignment. This increases the parental sense of responsibility that they're being asked to end their child's life. And over time, fosters a lack of trust between the family and the medical team, as more and more often the medical team is iterating that your child won't survive. The family then digs in further and feels they're being asked to make an unrealistic decision. This causes moral distress among the medical team, and ultimately the discussions with the parent focus on conflict rather than on high-quality end-of-life care.
When presented with the option of attempting CPR, parents hear that CPR may actually be potentially beneficial for their child, and even if we as healthcare providers disagree with that opinion. Parents are then feel obligated to make a decision to essentially end their child's life. And this creates a big sense of guilt within the parents. This parent reported, "The first feeling I got was guilt because it was like I would take away his life support, and what if there was a chance he could have survived?" Nelson also states, "Agreeing with a physician who has proposed foregoing treatment and allowing a child to die can provoke strong feelings of parental guilt and responsibility for causing the child's death. Often the consistency between loyalty to a child and allowing the child to die is not immediately obvious to many parents."
Our third vignette is that of a 9-year-old girl with static encephalopathy, seizure disorder, and BiPAP dependency. This child has an acute cardiopulmonary arrest with ventricular fibrillation. the ICU team arrives to the code blue and finds that the patient does in fact have a modified code status. And this is what's described at the instructions for the code team. Perform all interventions until able to discuss with mother at bedside. Provide time for mother to say goodbye. Avoid harmful or painful interventions. And the orders say use non-invasive respiratory support, bag, mask, ventilation, and oxygen. Clarify at the time of the event whether intubation is indicated. Okay to use epinephrine boluses and infusions of pressors, but no chest compressions or defibrillation. So that's what the team is facing, and this is an example of a code sheet from a patient such as this. So here's the patient being bagged. The physician here, while bagging is going on, continue to hand bag. Interpreter contacted to discuss if patient to be intubated. Down here, so discussion is going on. The physician talks with interpreter, choosing not to intubate, and writes the DNR order during this event. And down here we have the patient shaking their head. Because with the ongoing some degree of respiratory support, their stats are such that they're still conscious. So this, in my opinion, is inappropriate on several levels. It's inappropriate to ask the family to make this kind of decision in the heat of the moment. It's inappropriate to expect that the providers at the code team can realistically both resuscitate and engage in a discussion simultaneously. It's also inappropriate to have, a conscious patient overhear the dialogue about their survival. So ultimately, this patient was not resuscitated and went on to die. And it's unclear to me how much of this conversation they heard. But that's inexcusable of us to ask that over their patient's bedside. So it's the third challenge then, inappropriate expectation to review code status in depth with the family at the time of the arrest. And finally, our last challenge is that initially, approximately 12 years ago, we rewrote the limitation of resuscitation orders or DNR orders to be incredibly crystalline. We wanted there to be a real clarity about which components of resuscitation were to be done. And I think our current order set has achieved that. However, it was never intended to be used as an a la carte ordering mechanism. And unfortunately, what's happened is that rather than engage the family with what they would like in terms of goals, that occasionally the menu is asked of them, do you want this, and do you want that, and do you want the other thing? And that leads to a nonsensical combination of orders. So for example, asking that you would like defibrillation or epinephrine, but not both. In the case of VF arrest, it would make physiologic sense to perform both. If you're going to give epinephrine, you need to do chest compressions to circulate it. So you can't take these therapies apart and expect that the family is sophisticated or understands the components of them. So offering them in that mechanism has really created a nonsensical state for our code team to arrive to. And finally, to say that we want to do cardiac interventions, but we don't want to support the airway. Again, we're coming up with all kinds of combinations that don't make sense.
Nelson agrees with our disagreement with the menu of options approach. He states, in this age of informed consent, some physicians present all technically feasible options to parents of a critically ill child and offer to do whatever the parents want. Such vending machine medicine is inconsistent with good medical practice. Parents should not be left to decide about foregoing treatment on their own. They need and deserve the advice and support from the physician caring for their child. And some parents report that they really appreciate recommendations from their providers. The doctors helped me by giving me options for him not to suffer. He was very frank when he told me, as a physician, my opinion would be to just let him go. To me, that was very, very important.
So based on this, I'll go through the summary of what we felt were the most important challenges to overcome in the current state. The first was a lack of a consistent and clear documentation of the goals of care, as well as end-of-life conversations. There was nowhere in the record to consistently find what happened in these conversations. We have, in general, a lack of focus around goal-oriented conversations regarding options, more on the specifics of what you do want done, rather what you don't want done than what you do want done. We had a tendency toward inappropriate review of code status in depth at the time of arrest, and we wanted to very much promote pursuing these conversations well before we arrived at an arrest situation. And finally, we wanted to remove this menu of options approach that leads to orders that don't make physiologic sense. So in order to move forward with this, we formed a work group which was very much ad hoc. We asked a lot of people who we knew are interested in promoting end-of-life care, and formed a loose association of folks from the ethics group, the PAC team, our own administrative, legal, and regulatory personnel, social work, the chaplaincy office, child life specialists, and then many physicians and nurses. Believe it or not, we've been at this for about 2 years. We performed what we hoped was an extensive literature review around the pediatric resuscitation and limitation of care at the end of life. We evaluated what other institutions are doing, and our goal was to develop a policy and order set, which we then went on to revise unbelievably number of times. And once we had this in a pretty good draft form, we presented it to families, the hospital ethics committee, the hospital administration, and anesthesiology and surgery. So at this point, I'm going to switch gears a little and talk about some of the information that our process revealed on pediatric deaths.
So in order to understand our patient population that is most affected by our discussions and by our decisions made in terms of modifying our policy and our order set, we looked at some of our local statistics here at Seattle Children's Hospital. And as you can see here, the total number of deaths, this is approximately 2.5 years. This is from our quality improvement database. There have been approximately 250 deaths within the last 2.5 years. And the great majority of these deaths occur in the ICU, with another subset of deaths that occur on now the cancer care unit, the emergency department, and also in other, meaning acute care floor with the surgical and medical patients. We also reviewed the national statistics regarding pediatric resuscitation survival rates and pediatric deaths, and these numbers are actually a conglomeration of numerous papers that have been published revealing the epidemiology, so they are all arranged, and I understand the percentages do not add up to 100%. But in general, 10 to 40% of children with cardiac arrest will survive to hospital discharge, nationally speaking, and approximately 1/3 of these survivors have a good neurological outcome. Locally here at Seattle Children's, our rate is about 35 to 45% of our patients who suffer cardiac arrest in-house survive to discharge. And then nationally speaking, where do children typically die? These numbers only include patients who die in a hospital. This does not include any children who die in hospice care or at home or other locations. And so approximately 70 to 85% die in the intensive care unit, which is consistent with our local statistics. 40 to 60% die following the withdrawal life-sustaining therapies. 10 to 20% die after failed cardiopulmonary resuscitation, and then a small portion, the 15 to 30%, die from cardiac arrest while foregoing CPR, such as in the case of the children who have a DNR order that's actually written for them. So acknowledging that childhood death is a reality for all of us that we face in our current profession, I want to look back at how our current approach of obtaining permission from parents to forego CPR evolved. And we obtain this permission regardless of the clinical situation that that child may be in. And I ask, how do we adopt this opt-out approach rather than an opt-in approach to CPR, which is unlike most other medical interventions? And historically, in the 1960s, CPR started as an intervention. It was first performed by anesthesiologists in the OR who had witnessed a cardiac arrest, either in an adult or a pediatric patient. One of the first case series that was published in this area of CPR was actually a case series of 20 children who suffered from cardiac arrest in the OR. And of these 20 children, 8 survived, and 5 of these had no neurological sequelae. And based on this success in the OR, CPR then extended across as a national trend. And regardless of the clinical scenario, CPR was implemented. And once it became standard, then patients actually had to opt out of CPR, regardless of the reversibility of the clinical situation. And I personally believe that this is actually a fault of our medical system to not clearly define when CPR is probably an appropriate intervention versus when CPR is something that is just applied universally to all patients. And it's important to remember that CPR really did originate in the OR with a witnessed cardiac arrest with a reversible underlying problem, and that was what made it so successful. And the American Heart Association in 1974 actually did recognize that this may be a challenge. And they actually were quoted to say, resuscitation may represent a positive violation of the individual's right to die with dignity. And they recommended that physicians should write a note in the chart indicating that CPR may be contraindicated. And this note eventually became what we term as the DNR order. And this, I believe, represented a paradigm shift in medicine where all of a sudden we were actually having to obtain consent from families to forego a medical intervention. This is the first and only intervention that we ever have to ask permission from families to actually withhold this intervention. The American Heart Association strongly encouraged to include patients and families in this discussion, and they also stated the decision to withhold resuscitation will become effective only upon the informed choice of a competent patient or with an incompetent patient, such as a minor, to the extent that all appropriate family members are in agreement with the involved staff. Again, here there is a failure to acknowledge that CPR may not be medically appropriate in all circumstances. And in 1980s, there were physicians and philosophers alike who felt very uncomfortable with this universal consent to CPR. And they actually came up with two different terms to use, do not attempt resuscitation or DNAR, indicating that resuscitation is only an attempt at prolonging survival. It's not necessarily a 100% guarantee in order to communicate with families that it was an attempt. And the other aspect was allow a natural death, or AND. So many of you may have heard these terms in which providers would sit down with a family and say, we would like to recommend allowing natural death rather than performing CPR. So as pediatricians, we always have a challenge between balancing parental authority to make decisions versus our role as physicians to make recommendations. And the current new PC trend is parentalism as opposed to paternalism. But in general, it is a thought that we are making directive recommendations to a patient or telling them what they should or shouldn't do. And as pediatricians, we are constantly juggling this battle in everything that we do, many of the decisions that we make. Determining CPR, when performing CPR is futile, is a very challenging thing. The more you think about it, you recognize that futility itself defines on a subjective determination of the value of the benefit, the burden, the quality of life of the child. And all of this may be viewed differently by different stakeholders, such as the provider and the parents. For example, a provider may really feel that performing CPR is a futile intervention for somebody in a persistent vegetative state. Yet for the family, the actual act of performing chest compressions may actually be a message that they're sending out to the world that they are a parent and they are going to fight to the end for their child to survive forever. And for them, that symbolism of performing the chest compressions themselves may be very important to them and may be very valuable, and therefore CPR in that case could not be called actually futile. Historically, there have been multiple legal cases that have been presented in the setting of determining who gets to decide when a DNR order is written, essentially. And these legal cases, it's important to remember that these cases were actually cases that made it to the court system. They were not in the immediate code status situation that Dr. Roberts just presented. They actually had time to have these conversations and escalate it to the court system. So their first case is Karen Ann Quinlan, who many of you may be familiar with. She was a young woman who suffered from a severe anoxic brain injury in her early 20s, and her parents actually asked to remove the mechanical ventilator in addition to not perform cardiopulmonary resuscitation. And when this went to the court, the lower court stated that the decision may be concurred by parents but not governed by them, because there is always the dilemma of whether it is the conscious being's relief or the unconscious being's welfare that governs parental motivation. And the higher court then ruled, because it was actually moved up a level, that the decision-making should be controlled primarily within the patient-doctor-family relationship and not in the court system, highlighting the need to weigh the benefits and burdens of CPR in the medical system and not necessarily in the courts. And the second case is a case of Jane Doe. She was a 13-year-old young girl who suffered from a neurodegenerative disease of unclear etiology. And the judge ruled that both parents had to be in agreement for a DNR order. Otherwise, the physicians had to follow what they described as the statutory presumption that every patient is presumed consent to resuscitation. And in 1993, there was the case of baby K, who was an anencephalic infant whose mother refused a DNR order or wanted to continue with CPR and resuscitation of her child and actually requested continued mechanical ventilation. And the court took it away from the looking at whether or not CPR was medically indicated or appropriate and really put it to the statement of EMTALA, which is the federal mandate that all hospitals have to provide emergency medical care for all patients. And they require the physicians then to provide full resuscitation, including CPR and mechanical ventilation. Again, this ruling really neglected to look at the nuances of the benefits and burdens of CPR. And then finally, the case of Matthew W., which was a child who suffered from a severe traumatic brain injury in the setting of non-accidental trauma. The judge ruled that the rights of the parents to direct the care and upbringing of their children is unquestionably a fundamental right. Hence, a unilateral DNR order is only permissible after the parents have been notified and have been heard. In all four of these cases, in which there has been time to discuss the plans for resuscitation, we are definitely obligated to include families in these discussions. And ultimately, most of us will tend to make life and death decisions based on recommendations from the families or their in the best interest of the family. It's also important to remember, though, in the acute situation when you're immediately standing at the bedside, we as providers are only compelled to do what is medically appropriate. Despite the legal precedent that is set by these court cases and of including parents in these discussions, which I strongly believe is appropriate and important, regardless of the type of intervention, it is always important to remember we are not legally obligated to provide medical interventions that we believe are non-therapeutic. For example, during an actual code, when we are resuscitating a child, we ultimately, as the providers, make the decision as when to stop the resuscitation. We usually don't pause somewhere in the resuscitation, look to the parents and say, are you okay with us stopping at this time? Tomlinson and Brody explain that we can feel very uncomfortable as providers making moral decisions or value-based decisions, but I think it's important to remember that most of the medical recommendations we make are value-laden. They are based on medical society community culture that we have developed with our own community of medicine. And Tomlinson and Brody explain, to assert that the physician should not have this discretion is to deny the medical profession should have any power to interpret and apply its own defining values. In this case, the duty to do more good than harm to patients. Physicians retain the moral authority to make some decisions about the purposes to which his or her skills can be put. While we wholeheartedly choose to respect parental authority in making decisions for their children under most circumstances, I personally argue that there is an incredible value to the intimate parent-child relationship, which makes it very difficult for some parents to make the decision to forego CPR or choose to allow their child to die or fight to the end, or to let go of fighting to the end. Discussions regarding limitations of interventions at the end of life are never easy or welcomed by any parent. For the intimacy of this parent-child relationship makes it unfathomable for many of the parents to make these decisions. Throughout the course of a life-limiting illness for a child, the parent-child relationship never ends. And multiple factors play a crucial role in this relationship. First of all, parents identify themselves to their core as to who they are as a parent, and allowing death, in their opinion, is likely the ultimate harm for their child. And therefore, most parents are going to believe that everything needs to be done to prevent causing harm to their child or letting their child die. Losing a child for some parents may actually mean that they lose their identity of a parent if they only have one child, and it also means that they may lose their parental integrity of fighting to the end for their child. And secondly, most parents will hope for a never-ending survival of their child. That's a normal, natural instinct of every parent. And this is likely in the context of a parent recognizing themselves as a parent. And so letting go of this hope may be nearly impossible for some parents. And furthermore, when parents have a child who is diagnosed with a life-limiting illness, they have a loss of sense of control. Typically, with our children, we tend to be somewhat in control until adolescent years, I hear. But for the most sense, parents do feel like they have some sense of control of their family situation and what's going on for their children. But when there is a diagnosis of life-limiting illness, they lose that sense of control. And even furthermore, when this child gets put in the hospital, makes it even more challenging them to regain remain that control. And sometimes one of the things that helps them feel like they are in control is making this decision to really force towards prolonging the life of their child as long as possible. And in the last area, within the social context, childhood deaths in general are unnatural. We saw there's approximately 250 deaths within our own institution in the last 2.5 years, but these aren't well publicized. It's not, people know that old people die, but when it comes to children, it's very rare for parents to ever fathom that their child could ever die. And as Vicki Foreman stated in one of her books, she's the mother of the former premature infant, a parent should never have to bury their child. And so due to the intimacy of this parent-child relationship, we argue that while we respect parental authority to make decisions for their children, we as physicians also have a duty and an obligation to prevent parents from feeling like they have to destroy their relationship with their child or disrupt their integrity as a parent. And while physicians when physicians take responsibility and ownership for the recommendations to forego CPR, the integrity of this parent-child relationship can be preserved. Through dialogue and conversations, many parents do ultimately come to an understanding that protecting their child from harm sometimes actually means allowing them to die.
Physicians should not offer treatments that are physiologically futile or certain not to prolong life. Beyond that, they run the risk of giving opinions disguised as data from Youngner. To push the burden of a decision to omit a non-beneficial intervention onto the shoulders of the patient or the patient's family would be shirking one's duty as a doctor. From Paris.
Pediatricians have obligations to both their patients and to the parents of their patients. Yet it is important to remember that in the majority of circumstances, our primary obligation is to our patients or to the child. Mayer explains pediatricians must carefully consider that which is in the best interest of their child, while at the same time respecting parental values and authority. One may argue that when a child dies, it is the parents who live on after the death of their child, and therefore we should actually be prioritizing the parents over the child. Yet I personally believe we have to be very careful with drawing this conclusion, especially when this decision may be made at the expense of direct harm to the child.
A child cannot be treated solely as a means to achieve someone else's goals and ends, but must be treated simultaneously with respect to our own actual and developing goals and ends. From Ross.
So, practically speaking, how should we as providers make the decision to recommend foregoing CPR and to help guide our families on these unfathomable journeys? How do we ensure that we foster the intimate parent-child relationship rather than forcing parents to feel like they have to destroy it? We believe that the goals and tenets of the palliative care movement have really helped to achieve this goal. And Dr. Feutner has described palliative care as having 3 different domains. And the primary focus that we'll have for this domain is at the top here, the problem solving and decision making, in which we look at a problem or a predicament, come up with options and treatments, and interlinked with this are the goals and hopes. And this is how we hope to guide our medical care. However, the question has always remained, when do we bring palliative care into this picture? Many patients with life-limiting illnesses may live all through childhood and even into early adulthood. And so when does palliative care get instituted into this, or the principles of palliative care get instituted into the care for this child? And Dr. Feutner has diagrammed the history of palliative care with these 3 different diagrams. And historically, the diagram at the top, number 1, shows that curative care and palliative care are 2 distinct entities, and that at some point in time there is a switch from curative to palliative care. But there's been much discussion in the literature that that point between these 2 is very difficult to define or determine, and that model has really fallen out of favor in terms of looking at what the purpose and goal of palliative care. And the number 2 model reveals that curative care and palliative care overlap a little bit more. There's not such a clear, distinct point in time where they change. But again, they are still competing. As curative care diminishes, then palliative care increases. And again, Dr. Feutner at least believes that this model, again, does not represent the true meaning of what palliative care should achieve. And the third model is one that he developed, where these are all different types of complementary care and concurrent components of the care that we provide. And at the time of diagnosis, which you can see the timeline at the bottom of the screen, there's cure-seeking care, life-extending care, and then quality of life and comfort-maximizing care, all which start at the time of diagnosis. And over time, cure-seeking care may no longer exist, but life-extending care continues, and then quality of life and comfort-maximizing care is the one that persists the longest as a child or a patient nears death. I believe that those models of palliative care can actually help providers understand where a child may be along this pathway, and therefore may be able to determine a little bit better to some extent when they should start making recommendations to forego interventions such as CPR. And Dr. Funer also has a diagram about the role and the goal of palliative care. And the purple on these diagrams all reveal that this is where palliative care may step in to help benefit the quality of life for a patient. You can see here on the y-axis is quality of life. On the x-axis is over time for all of these diagrams. And these are different patterns or pathways to dying. For this purpose of this talk, I like to focus on C and D, whereas I find many of our patients fit into these two categories. For Model C, you can see there's actually a fluctuating decline in the quality of life of this patient. So they start at 100%, and then they are diagnosed with a life-limiting illness. They may have an ICU admission, which is where it drops down. The child recovers to some extent, goes home, but not back at the baseline they were at the start. And then they have another decline, and they bounce back up. The purple line indicates that towards the end of life, or on that downward slope, the palliative care may actually help with improving the quality of life for that child. And in figure D, this is a medically fragile child, someone who is born with a congenital anomaly or something that will keep them in the hospital for most of their time or their life. And you can see again that's this downward descending curve of a fluctuating decline in terms of their quality of life. And again, palliative care can step in to really help with that. We personally believe that by highlighting the goals of care, we can actually make recommendations accordingly and ultimately provide our parents with the support that they need during the worst situation in their lives. Rather than creating conflict as we presented in some of our anecdotal cases, we believe that really having conversations with families about their goals, incorporating that with our advice can lead to a high quality of death. This negates the fact of actually sitting down with a family and giving them a menu of non-therapeutic options in some circumstances.
Focus the discussion on what the family does want for their child, focusing on things that they have control over. The family can set goals that they can achieve. The clinician then partners with the family by describing the clinical interventions that most effectively achieve the family's hope and goals. From CLIC.
So again, practically speaking, it is difficult to develop a model based on these theoretical discussions of how we sit down with a family and have these conversations. And Blinderman et al. In 2012 published an article in JAMA that really tried to piece out a model for having these conversations with families. And they argued for a three-tier approach, which involved three different options for families and how they presented CPR to the family. And the first option was consider CPR as a plausible option. The second one was recommend against CPR. And the third one was do not offer CPR. And so for the first model, as CPR is a plausible option, this is typically in patients with a chronic disease that is not necessarily in the terminal stages. The relative harms and benefits of CPR are uncertain, and the physician has an obligation to clarify that the patient and family really understands the disease process, and the physician also has an obligation to discuss the potential benefits and risks of attempting CPR. And then the physician is again obligated to have a guided discussion with the family about the goals and values, and then ultimately determine what appropriate medical interventions should take place in this setting. In the second category of patients, these are patients who suffer from a chronic disease in the terminal stages, where there is definitely a low likelihood of benefit from CPR and a high likelihood of harm from CPR. And in these circumstances, I understand it's really hard to necessarily 100% judge when the disease is actually in the terminal stages. But I think that in general, we all get a sense as somebody is going down one of those patterns of dying, we can actually get an intrinsic sense, an instinctive sense as a provider where this patient is headed. And at this time, Blinderman actually recommends that we recommend against CPR, and we only have to obtain assent from the family to forego CPR for them. Rather than having to obtain consent and making them make the decision, we say we recommend against it, and they say, okay, I agree. That's essentially what assent is. If there's a disagreement based on the goals and the values of the family, then Blinderman still argues that we should likely attempt CPR. This may be for the specific family where the actual process or symbolic nature of performing CPR itself is of high value to this family. And in the last situation, Blinderman feels that these are for patients who have imminent death with no chance of survival leaving the hospital, such as a patient who has the diagnosis of brain death, might fit into this category. And the family is then informed, and the patient and family is informed the plan to forego CPR. The physician doesn't even bring it up as an option. They just mention to the family, we're not performing CPR. And in this setting, Blinder argues that the physician actually has an ethical obligation to not perform CPR in these situations. If we were to perform CPR in these situations, we are actually doing harm to the patient, which is against our integrity as a physician. And so he argues that in this setting, if there's actual conflict between the provider and the family, that an ethics consult should be obtained, and then the hospital policy and procedure for conflict between providers and families should actually occur. So we modeled our model to some extent off of Bleiderman. We didn't go to the extremes of all of the clinical scenarios that he has in his recommendation. But we also wanted to discuss our model or our thoughts with the family advocacy group. We do feel strongly that families should have a huge input into these discussions, as it is their lives and their child's deaths that we're talking about. It's not about us, it's about them. And so we met with the family advocacy group to run our proposal by them. And they brought up some interesting thoughts that they wanted to share with everyone. First of all, they requested that providers attempt to meet families where they are at. There were different parents in the room who had lost a child at Seattle Children's, and some parents reported that when they were asked about limitation of resuscitation, they felt that it was too early in the course of their child's life, and they felt that at this time they became very angry and even more adamant for prolonging the survival of their child. There were other parents in the room who actually said, it was too late when this discussion was brought up. We felt that we had to cause our child undue suffering and harm. And in this situation, we were very uncomfortable with that situation, that we realized that we made our child suffer for an extra 2 years, is what one of the parents had actually said. And we recognize, though, as providers, that the art of medicine really comes into play here when you're trying to decide where are you meeting the families. And there are often times that we as providers will probably make the mistake of either bringing it up too early or too late. But we want to encourage, because no parent ever wants to have this discussion, encourage that these dialogues do happen. They do happen early enough that there can be thoughtful decisions made as the child progresses along the course of the disease. In the second category, they requested that providers actually have multiple and ongoing conversations with families. This is not something that can be decided in one sit-down discussion with the family. One of the families requested that physicians think about artfully planting the seeds for the steps that may occur in the future. And another parent actually said, create a roadmap for where these decision points may actually occur in the course of a child's illness. And then another aspect that they said is definitely to improve communication among the medical team. Many of them had felt the frustration of a new provider, new team, getting asked the same questions over and over. And so they requested that we have accurate and accessible documentation. They even went to request that some of this documentation be reviewed by them prior to being entered into the medical chart. They requested that all providers who walk in the room share a consistent message. It's very confusing for a family to hear from one provider that CPR is not indicated and then hear from another provider that potentially we could do CPR. And to communicate with the primary care provider, so at the time of discharge, the family doesn't have to go to the primary care provider and relive all of those discussions that they've just had. And then they also requested, if possible, which we know is logistically and realistically challenging, to maintain a continuity of providers who have these in-depth conversations with the family. They also recommended that the language that we use is very essential and very important to helping them make the decision, such as instead of saying we won't be performing CPR on your child, to say we will do everything for your child, including providing him with a good death. The second that they thought was really important is to make it clear that we do not want to cause harm through providing CPR without providing any benefit to the child. And the last one is that they really thought that some of the papers that Dr. Feutner has written on hope, and hope comes in many different types of forms and things, and to really express that to families explicitly so that they can understand that hope for survival may no longer be a realistic hope, but there are still many other hopes for the legacy of their child living on. And then the last one that they said to help with understanding where a parent is at is that they really said that when a child with a chronic illness is admitted to the hospital, with each admission, it may be important for the provider to sit down with the family and actually review what are the goals for this admission. Is the child at a new baseline where we need to make some different decisions about what we would do if the child were to get sicker? Or is this child, do we expect a full recovery with this admission from whatever the child has?
So taking all of that, all of this discussion, all of this evidence, and a lack clearly of an opportunity to have much dialogue between all of you who are our providers here, we were faced with a challenge of what we could try to create that would work for all of you. Everyone in this room, I'm sure, has different underpinnings of what they feel comfortable recommending to a family or not. And the principal thing that we took away from all of our discussion was that we thought talking to people was better than not talking to them. And having a place to write that down made sense. So all of this we translated into some fundamental changes into CIS, and then the rest really will be up to you. So our policy was created with certain tenets. We wanted to allow and encourage the documentation of discussions regarding the goals of medical care, limitation of resuscitation, or end-of-life decisions. We wanted to provide an easily accessible written record of these discussions to avoid unnecessary repetition of emotional and complex discussions for families. Families told us that getting admitted here with your complex child was like going on 50 first dates, bad first dates, because we all come in and talk to them over and over and over again, and it's an incredible drain on them. To provide guidance to healthcare providers about the rationale and procedure for writing limitation of orders. There's a lot of lore in our system and not so much fact. And finally, to provide medical providers a clear and explicit plan for resuscitation prior to an emergency. That part will be up to you if these conversations occur beforehand. And finally, to bundle care decisions into physiologically grouped choices so that we couldn't make erratic and nonsensical choices. So the policy outlines an algorithm based loosely on what we saw from Blinderman, with the goal of having the physicians take more responsibility for not offering a la carte choices, but for recommending what you as a physician think is plausible. And the degree to which you are pursuing these conversations is really at your discretion. What we would recommend is that the attending physician discuss the goals of care with parents and, if possible, the patient, and then determine if resuscitation is medically indicated within the context of these goals. At that point, the physician really has to determine whether or not, based on what the family has said and the medical condition of the patient, whether or not CPR is a plausible option or not. If it is a plausible option, then offering that to families makes sense. If it's not a reasonable option in your mind, it makes sense to say something where you are actively recommending against resuscitation due to the likelihood of harm over benefit. And not being sure to not frame the question that we would like families to own the medical decision making about appropriateness. They can own the decision about where they'd like to head next, but the onus is on us to decide whether or not we think it's medically plausible. Then the attending will support the decision of the parents for full or limited resuscitation and document that. So just to be clear, we have left out unilateral DNR where the physician is saying, regardless of what the family wants, we won't pursue resuscitation. The writing of these orders, regardless of the outcome, will be documented in CIS, and we want this to become habit for people. We would like to have the goals of care expressed regarding which, and then translated from the goals into the actual practice of care. We don't want to ask parents any longer what menu items they wish, and we want them to make physiologic sense. Orders will then be documented electronically and printed by the unit coordinator, as is done now, and may be rescinded or modified at any time. These discussions are meant to be ongoing and can be updated at any point. So this is a screenshot of the revised order set. As you can see, we've put the discussion section prominently at the beginning. And it doesn't matter if you change anything in the orders. What matters is that you say who was there, what was going on the time you talked about it, and what the family wanted, regardless of whether or not you decide at that point in time to make any change. And then ongoing providers can come and reference this and say, I see last time this is roughly what you wanted to do. Is that still what you want? Oh, I'm sorry, one more thing. We bundled the support levels into 3 groups: non-invasive respiratory support, invasive respiratory support, and cardiovascular resuscitation. And truly, we made it so that you can't choose cardiovascular resuscitation without choosing invasive respiratory support. So they tiered levels of support to which you can add only. This is a screenshot of the patient summary page that will be forthcoming. The date that the most recent documentation of any kind of discussion of end-of-life goals will be here. And there's really 3 things that can show up here. One is that it's not been discussed with this family, and you can assume full support. You could say this has been discussed with them on a previous admission and needs to be updated this admission. Or you can say it's been discussed this admission, and you can go and look at the form and see what the family wants done. There's clarity in the policy around hospital admissions, that each admission needs a new review of code status. What to do, I'm going to go quickly here because I want a little time for questions. What to do if the attending is not in-house, and how to make sure that the orders are in place even if the attending isn't present. What to do at the time of discharge is outlined in the policy. And finally, what we'd like to conclude with is that this may look like very little change in CIS to try to equate to a great big cultural change. But we're hoping that this is a starting place to improve communication and optimize documentation regarding limitation of resuscitation, and really what goes before that as well. We'd like to impart the message that physicians have an obligation and a duty to take responsibility to recommend against providing CPR if that makes clinical sense to you. We would like to emphasize a goal-oriented approach that optimizes family involvement, enhances the physician, parent, and child relationship, and works towards alignment rather than conflict to ultimately improve the quality of life and death.
And one of the mothers who published an anecdotal story about her child who had a life-threatening illness with a progressive neurodegenerative disease. She said she went through a year of hospitalizations trying to define a curative therapy for this undefined neurodegenerative disease. And ultimately, she met with a palliative care specialist who really opened her horizons and views to what she could actually achieve for her child. And she really emphasized that the dialogue was really the most important part of her care that she received during that year of her child's life. And she stated, "For dialogue is not about providing answers so much as creating a meeting point where it becomes possible to embrace the mess and fallibility of simply being human. What we do not know can paradoxically be as reassuring and grounding as what we do know and what we can be certain of. For after all, death is the only certainty we all face." Put simply, we were listening together in a living presence, and within this dialogue, a precious and choiceful truth opened up for us, the possibility of Amelia living and dying well. Her daughter was subsequently discharged to home within a few months after the conversation with the palliative care specialist. Her daughter lived for 6 more months at home, and she cherished those last 6 months with her, saying that her daughter was able to have both a high quality of life and a high quality of death. We'd like to open this up for any type of questions.
So really, really great talk and great effort. I think that's a really good summary, I think, of the evolution that many of us have made over the years. The only probably somewhat subtle distinction I would say is in the issue of at the point of when we are recommending, and I guess personally, I think I've found that even asking assent is a burden, and I think that having the opt-out left to the parent, but saying we are not going to do this, and not require an assent, I think personally is yet one level. And obviously, if they disagree, then we're going to have to go another level. But I think that's one less burden for the families to bear. So assent is not something I ask for.
We completely agree. There's such an incredible spectrum of comfort level in the conversations that people have with families. In our interviews with many of the practitioners here, we were unable to come to any kind of alignment amongst the bulk of the ICU and hem-onc, where we see many of the deaths. So it was very challenging for us to find an algorithm that would work for all.
Thanks very much for this incredibly hard work that you guys have done. Last night I had to live through quite a bit of this, caring for a teenager that was functionally decapitated with intact skin around his neck. My one question for you is, did you consider somewhere in here ECPR? This comes up for us a lot as knowing when, who is a candidate for it, and the candidacy is often hard to determine, especially in the middle of a code. And just curious if that has come up in terms of an advanced recognition that maybe we can do all of these things, but not ECMO.
So we can both answer. So in a practical sense, any attending in the hospital is capable of entering the do not resuscitate or the limitation of resuscitation orders, but not every physician in the hospital is capable of determining the appropriateness of ECLS. And so to put it in this order set would not be appropriate. What we do anticipate, however, is that by elaborating where the family feels, what they feel is important for their child, will add clarity to the people at the bedside trying to make that decision. But it's a distinction a little bit between the people who are doing this conversation may not have the expertise in ECLS to help determine that.
And so I think that's next steps too. We started really with CPR as one intervention and started slow with trying to just kind of shift cultural change of not having the menu of options approach. And next steps, I think, in the future, definitely with some other work that we're doing, is looking into ECLS and specifically ECPR and informed consent for those processes.
Oh, great. Thanks very much. That was really a lot of work. I had one comment and two questions, I think. So one comment is I love not having the menu, because as someone who's not someone who actually does a lot of the resuscitation myself, I even feel the further away I get from being a resident, the more I worry I would pick the wrong things on our previous that, to set that up. So I really love that. And then the two questions I have is, one, is some of this work around what to do when there are even more people at the attending level, and especially being a teaching hospital, how we, when the conflict isn't between patient but medical providers, and the patients of course pick up on that, like what is part of the work around how we do that and how we handle that. And then two, whether this is going to expand to talk about when we also withdraw care in addition to this talk about. So that's a lot. Thanks.
So to
Two
start
simple
with,
questions.
oh, yeah, really straightforward. We have not actually addressed when there's conflict among providers within that. We would recommend, though, that be resolved before these things are presented to a patient. And did we come up with a good way of conflict resolution? Not yet, but that could be also future work. And in terms of your second question was, remind me.
Around withholding.
Withholding and foregoing. That is the next step. That is a policy that also will need to be updated in the setting of this policy coming out. So,
I think the two things are very much linked. That in our patient populations, sometimes we arrive at the state of resuscitation being the decision point, but more often than not, it's the long lead-up time prior to this event that is really the bulk of the patient experience that is either very positive, very negative, how we can work on that.
Seeing no other questions, as the moderator, I commend to you to going to the website and looking at Ann Thompson's presentation from 2 weeks ago. It will take you another step beyond in this conversation. This is really important work, and it's really important communication. And I wish we could say it was never attached to conflict, but it often is. Can we give them a big hand, please?